All right, my name is Gloria Coronado, and I am the Associate Director for Population Sciences at the University of Arizona Cancer Center. I'm also the proud Vice Chair of the NCCRT, and I grew up in a rural community in Eastern Washington, so really happy to be moderating this panel. So this panel is on colorectal cancer health equity, barriers and solutions to reaching rural communities for colorectal cancer screening. And so I think what we're going to do is hear some of the successes and challenges of work being done in rural communities. So just to begin, I want to set the stage a little bit about rural communities. So we know that colorectal cancer incidence is about 16 percentage points higher in rural areas than in metropolitan areas. We know that among those who have a colorectal cancer diagnosis, that 2 out of 3 living in rural areas are diagnosed at a late stage. This compares to about 60% in urban communities. We know that there's an important screening gap, that people that live in rural communities have lower rates of screening. And there's an important healthcare workforce shortage issue, with 66% of primary care health professional shortage areas being in rural counties in the US. We also know that in rural communities, there's a higher prevalence of modifiable risk factors like smoking, overweight and obesity, and low levels of physical activity. So here today to talk more about rural health, we have 3 panelists. So Dr. Paula Chatterjee, who is a physician and the Director of Health Equity Research at the Leonard Davis Institute for Health Economics. She's also Assistant Professor of Medicine at Perelman School of Medicine at the University of Pennsylvania. We also have Patty Molina, who's a Senior Director of Community Health Services for Mariposa Community Health Center in Nogales, Arizona. And we have Brent Wallis, who's Chief Medical Officer of People's Health, and he's a chair of the Louisiana Payors Council and founding member of Taking Aim at Cancer in Louisiana. And notably, he's a 2025 National Achievement Award honoree of the NCCRT. So welcome all of you to the panel. So Paula, I'm going to start with you. So in 2023, you published an article that said rural hospitals and healthcare systems have been in a slow-burning crisis for decades. Say more.
Nothing like having your own words read back to you to try and defend them. So thank you so much for the chance to be here. This is my first time at this conference, and it's just been so wonderful to meet you all. I am a little bit of an interloper. I spend most of my time thinking about health policy. I'm a general internist for part of my other time, and I try and think about healthcare delivery a little bit from the 30,000-foot view, so please forgive me for the inherent limitations that comes with sometimes. When it comes to rural healthcare challenges in the United States, what I'll say is that these are long-standing challenges that we are trying to think about anew. So when I think about writing introductions to my papers, I can go back to papers from the 90s and the 80s and find the exact same stories being told. Rural hospitals are closing, rural people are dying at higher rates and at younger ages, and we don't have good answers for these population health disparities, which are outsized compared to a lot of other disparities that we think about and certainly need to prioritize as well. So I think for me, step one is realizing these are long-standing challenges that we have tried really hard to address. I'll say one of the tools that we've used to try and address the rural healthcare challenge is payment. I know I don't get invited to a lot of parties because I talk about money and think about money a lot, and so forgive me, but payment is honestly one of the main strategies that we've tried to deploy to help rural healthcare facilities. These come in a lot of different shapes and forms. They come from state governments, federal governments, a variety of different flavors, but all of them are trying to kind of do similar things. They're trying to address what people describe as a fundamental market challenge, right? There's few people there. We have fee-for-service healthcare. You pay people for doing stuff. If there's fewer people there, there's less stuff to do, so you're paid less. A lot of our financial strategies have been to try to pay a little bit more, but it's often not enough. A lot of our strategies are trying to give financial predictability to rural healthcare facilities. But what does predictable even look like in a lot of these contexts when if you have like a 1 or 2 patient change from day to day in who you're serving, that can just have huge ripple effects. So I will say there's been a lot of attempts to use payment as a lever to address these rural healthcare challenges, and I'm still writing the same introductions to papers. Rural hospitals are closing, rural people are dying at faster rates in younger ages. I'm happy to talk later about reasons for why I think some of these strategies might not be realizing their full potential. I won't right now, but what I'll say is that I think rural healthcare is coming up against a new set of challenges as we enter the next couple of years. A lot of these are related to payment and financing, forgive me. We know that rural healthcare facilities rely on public payers a lot, right? Medicare, Medicaid, I don't have to tell this to many of you who, this is reality for. I think the changes that we're gonna see to the Medicaid program are gonna be really substantial and challenging. I'm happy to talk about that if that's of interest. I also think that there's just a lot of other decisions that states are having to make about their funding priorities, and that introduces new levels of uncertainty that, again, are hard if you can't sort of weather uncertainty because you don't have the denominator to do so. And so I think it's a hard and interesting and challenging time to be thinking about rural health. I'm a perennial optimist. Take it or leave it. But I will say that there's some policy optimism about rural healthcare. I don't know if many of you are familiar, there's something called the Rural Health Transformation Program. This was a piece that was built into the One Big Beautiful Bill passed in earlier this year in July. And the purpose of this program was really to say, hey, we understand that there's gonna be some financing challenges coming down the pike. Here is a big pot of money for states to apply for to try and bolster rural health infrastructure and rural infrastructure more broadly. We'll see how it shakes out. There's pluses to that program, there's minuses to that program. There's a nice amount of flexibility, which I think matters when there's beautiful heterogeneity in rural America that we need to address. So that's the perennial optimist in me. Excited to see what's coming, but reasons to be worried a little.
Thank you. Patty, we're going to get to you next. So the health center that you work at, Mariposa Health Center, operates 6 clinics in Santa Cruz County, Arizona. The county population is about 50,000, and the county median household income is about 53,000. The poverty rate is 20%, and the county is 83% Hispanic. You have had a lot of success using community health workers. Can you just describe more about what community health workers have done related to colorectal cancer screening and follow-up?
Sure, of course. So because of the fact the community is primarily Hispanic, a lot of the utilization of community health workers is important for our population. One, because the community health workers themselves are members of the community. They come from the community, they speak the language, they know the norms, the cultures. They also are familiar with services that patients think that they can't get the services that they want in the United States, they're gonna go into Mexico because it's right across the border to try to get support there. So they're familiar with those systems that they can try to either persuade them to continue their care in the United States or come up with a plan to navigate the system with services in Mexico, because there are a lot of oncologists in Mexico that can provide services as well if they're not going to do it in the United States. But the majority of it is there's beliefs in many of the populations in terms of the Hispanic population where they don't want to know. They don't want to go through the screening process, or they don't want to go and get the support because they don't want to know what the answer is to that test that they're going to get. And then they're afraid about what they're going to do. So with colorectal cancer, one of the things that our community health workers have been doing is really kind of honing in and focusing with those patients particularly, and providing them the one-on-one support, and be able to be that system of care for their continued care. So with a lot of the screening tools, whether it's a fit kit or the use of Cologuard, or trying to navigate the system to try to get them for a colonoscopy, the CHW has been the one that's there, helping to make those appointments, helping to provide arrangements or make arrangements for transportation. There is no public transportation in our area. And so in our area, also Santa Cruz County, there is no oncology care. So a lot of the patients, in terms of any type of treatment, even for screening, if they need a colonoscopy, there is no GI care in our area. They have to travel anywhere from 50 to 65 miles north just to get that. So this is what the CHW is also doing, providing that care and making that navigation for the patient to make it easier for them to get the services that they need. And it doesn't end at just providing the transportation, but helping them with the check-in process. Sometimes they are either underinsured or they have no insurance, and so they can't cover that. And so the CHW is helping to find support services to help pay for this as well. And that's another piece that they're doing too. So it's really an entire navigation of the system. And then being there to come back with them and then continue the care for them there too. With any of the at-home kits too, the CHWs have been the #1 person that the patient can call to get additional support, because maybe they just didn't understand what to do with the kit. So the CHW is either there a phone call away. The CHW can even go to the patient's home and show them there how to do the kit. Not the whole process, of course. But just kind of really going through that, showing them friendly videos or just going through pictures and just going through that thing, because it's just an easier step for the patient to understand. It's at a different level than when they're at the provider's office, and it's somewhat like the survivors that we're up here talking about, is really at that language and that point where the patient feels a lot more comfortable and safe. And does they have their questions answered? That's an important thing to answer. So the CHW caring for patients in terms of screening has been able to, for us, increase that measure as an FQHC. It's a quality measure that we have to meet, and so it has been able to do that just because of their help and their support.
Wonderful, thank you. Brent, we're gonna move on to you. And I just want to say a few words about Taking Aim at Cancer, which is a statewide initiative that's bringing together leaders from various sectors like healthcare, business, government, community advocacy, philanthropy, and more to improve cancer outcomes in Louisiana. Louisiana is has one of the highest cancer mortality rates in the nation, with significant disparities across racial and socioeconomic lines. So really excited to see that work getting honored. I want to talk to you specifically about your role kind of from the payer perspective and what you see as the role that the payer can serve to improve rural colorectal cancer screening and follow-up.
Sure, I was a little scared what your question might be, since I am on the payer side. But I do wear a lot of hats, so I'll kind of start off by saying I am a primary care physician. I am a med-peds physician. I actually am still in practice, but I am the chief medical officer for a relatively large Medicare Advantage health plan throughout the state of Louisiana. And we have kind of a unique history in that we were started by physicians, many of which were primary care physicians. It was a conglomeration of IPAs 25, 30 years ago that actually had the idea to start the organization. So we have sort of a DNA in us that's different from a lot of payers. And so one of the, one of the focuses that we have really honed in on is kind of twofold. Member-based interventions are extremely critical. And though we started in New Orleans, we are now statewide, and probably over 30% of our members are in rural areas. Over 55% of them are in special needs plans as well. So there's a lot of issues with health equity. And so what we did on the member side is we definitely created a very robust navigation program. I actually have over 100 RNs and probably a couple of dozen social workers that are reaching out to the members to try to drive all of their quality gap closures, and then also helping with navigation for difficult disease identification. Another kind of unique thing we did on the payer side is we actually created what we call service centers. So these service centers are actually brick and mortar clinics per se, that are staffed by nurse practitioners. And through these centers, and then actually directed out from the centers because we do home visits as well, we actually conduct about 40,000 visits with members. And we perform wellness exams, but really what we're doing is we're creating a plan of care for the patient, identifying where those gaps are, and then figuring out how we can help them navigate through the system to close all of those gaps. And I think that's helped us be real successful. And then if I kind of shift onto the payer side, or onto the provider side, so the most important thing to me, and it's not just because I'm a PCP, but we don't get paid very much. So I'm glad you brought up payment. One of the things I've done over the last 10 years is really try to figure out how we can get more money to the providers. And it is very, very difficult to figure out how to do that. And so one of the ways we've really done it is through value-based contracting. So over 65% of our primary care providers are actually within a value-based agreement. And so in those agreements, we're able to push up to probably 130% of the Medicare fee-for-service rates, which actually provides more dollars for them to get their own navigators, staff their clinics appropriately so that they can identify all of these diseases and then actually help navigate and treat them. And our goal is really to get up to 80%. So in that, we actually have also opened clinics. So we actually have primary care clinics throughout the state as well. They all operate in a payer agnostic way, so they're not just our payer, they're actually any payer, and they work under this value-based model. And they, along with a clinically integrated network, which is comprised of about 52 providers, PCP providers, mostly in rural areas throughout the state, we're able to funnel more of those dollars down to them so they can do what needs to be done. So lots of work to do.
Yeah, so just to say more about your values-based model, is that incentivizing based on meeting metrics, quality metrics across a variety of outcomes?
Yeah, absolutely.
Okay.
So, and we do it kind of in two different ways. In our clinically integrated networks, we actually place about 30% of the value dollars into quality metrics. So, and that includes all cancer screening, but also some other metrics that we have. So it's a pretty significant dollar value going back to the docs.
Yeah, that's great. So earlier today, there was a conversation about a new metric for time to initiation of treatment for colorectal cancer, and obviously, or even time to kind of follow up colonoscopy among those with an abnormal, non-invasive test result. And Dr. Lieberman talked about one of the main challenges is not having access to information about the test result. Just wanted to hear from you, given kind of your experience as a payer. Are there some solutions there that we're not seeing? What have you done that could be useful there?
So first I'll say payers are terrible because they don't really want to share any of their data. And that's a problem because you have to share the data to make all of this work. And so, you mentioned Tackle that we were a founding member of, and I am the chair for the Payer Council. And what the Payer Council is, it's kind of very unique in that we actually gathered all the MCOs, the commercial plans, and the MA payers in the state, and actually kind of locked everyone in a room together and said, okay, here's what we've got to do. We are always number 50 or number 49 on the outcomes list. What can we do to change this trajectory? And our first, decision was on colorectal cancer screening. And so, interestingly, at first everybody was very resistant, but over a period of time and with a lot of nudging, we actually got everyone to share their data. And so we actually created a repository, and we're hoping actually later this year we'll be able to roll out a state-based registry, which actually has not just all the payer data, but it also has health system data and smaller EMR data. And the reason it's so critical, and this is what the payers had to recognize as well, is that people hop from plan to plan, and their data doesn't flow with them. And so there were potential savings. That's what you always have to do with Payors. There has to be an ROI. So there were potential savings in screening that had already been performed that didn't need to be repeated. And we were able to highlight those, and I think we're moving in a good direction.
That is amazing. I'm so glad I asked. You had the solution or all there. That's great. Paula, getting back to you. So I know that, prior to COVID, telehealth was reimbursed for practices in rural areas, and then with COVID, it was expanded to urban communities as well. What is your thought about telehealth and its reimbursement, and is there more that we could do or should do to promote that?
I think telehealth can be a really potent tool in the right place. I think when you're talking about a lot of rural communities, you have to start with a conversation about broadband access, right? And so broadband access remains a challenge in a sizable part of America, which might be surprising to some people. The Biden administration had some really creative financial incentives to try and get communities to contract with broadband providers at a tremendous subsidy, and see if that might help, improve broadband access so that you can realize the full potential of telemedicine. Few communities took it up. Part of it was just, maybe maybe better advertising might have helped, but it ends up being a tremendously local question, and if there is local demand for the broadband to drive the uptake of these subsidies. So I think question one is do we have the infrastructure to realize the full potential of telemedicine? I think question two is that there are still some things in medicine that you still need to see people for, colonoscopy, and so I think telemedicine can be a tremendous asset for getting people through the door of healthcare, but then again receiving the full complement of care that they need. You still run into some of these infrastructure challenges. I find myself thinking about a paper that came out last year that has just I think about it probably more often than I should. Many of you might be familiar with the Health Professions Shortage Program, the HPSA program. This is something that was started in the 1960s to try and recruit physicians to rural areas. It comes with loan forgiveness, other financial incentives. They did a 50-year evaluation of the HPSA program and found that it was associated with no changes in the physician workforce, and that if you were a HPSA when that program started, meaning if your area was a designated shortage area, 75% of those counties still remained shortage areas. And so, I find myself going back to a lot of this evidence and trying to say, it feels like we should try some different stuff now. It feels like a good time to do a referendum on a lot of really well-intentioned, well-resourced policies and see if maybe there are other ways for us to think about this. But that's a little afield from your question about telemedicine, which I think has tremendous promise if complemented with broadband and other infrastructure.
No, and I see we're back to that slow burning crisis. It's the same.
I'm a one-track mind.
The deja vu is happening over and over. Patty, I wanted to just kind of build on the question and say, are you using any digital tools with your community health workers? Do they use videos or anything to educate patients?
Yes, actually we do. So like I said, the CHWs could go to the patient's home, and then they have little tablets, and they can show videos on how to actually do any of the fit tests or the Cologuard and how to do that at home, so they're able to do that too. The other model with either telehealth is where we're at, very rural, so their broadband is low in a lot of areas. So we have hotspots that the CHW could go with the patient, and to be able to kind of hook that up to their phone or computer or whatever they have, so that they're able to have a either telehealth appointment or something else like that too.
That's really creative. So another hotspot, so we learned about geographic hotspots, so these are broadband hotspots that are being used by community health workers. That's such a great idea. Brent, anything to add from your perspective?
Yeah, from the payer perspective, so we actually built telehealth into our benefits for fear that they would be eliminated. And that did happen for a period of time. So we do use it extensively. We actually, like Patty, we use an interesting model where we partnered with an EMT company, and they have a bunch of EMTs that want to pick up extra shifts, and they will actually go out to patients' homes in smaller communities and then tele-video back to our doctors. So it's sort of a facilitated televisit, And it really provides a lot of really useful information rather than just being, screen to screen.
That's great. It's almost like reverse telehealth, right? Like the doctor's not calling you, they're calling the doctor and getting support and setting that up in their home. That's really innovative. So one of the things that we heard in the conversation yesterday is when you see one rural community, you've seen one rural community. There's a lot of heterogeneity. We also know that there's already been a lot of policy changes with Medicaid. I know in the state of Arizona, when you look at comparisons over the past year, there's already been a reduction of about 10% in Medicaid enrollees, and that's likely due to the rollbacks of the policies, the COVID-era policies that allowed patients to remain on Medicaid without needing to show proof that they qualified. And we're expecting more coming down the pike. And so for all of you, you're either thinking about and working in environments where there's just tremendous uncertainty. Is there anything that, any words of wisdom or anything that you do to kind of manage that uncertainty in the rural environment in particular? Anybody can answer.
You take that. Just percolating in tremendous anxiety most of the time, but as it pertains,
like the rest of us.
like just the communal anxiety. As it pertains specifically to Medicaid, I think that there are some really, states are being forced to innovate the crap out of stuff, right? Forgive me. But this time is demanding them to do tremendously creative things. The conversations that our team is having with states is some of them are specifically related to the work requirements that are coming down the pike, where now individuals to remain enrolled in their Medicaid will now need to provide proof that they've engaged in either employment or some sort of community-related activities for a certain number of hours per month, and then that is now a requirement to remain eligible and enrolled in your Medicaid. Work requirements have been talked about again since the 80s by different policymakers. It's the first time that they will be rolled out nationally, and it's a tremendous administrative task. During the COVID-related unwinding, I can give you the story in Pennsylvania, which is that we knew that there were folks who might be at risk of losing their coverage. Pennsylvania actually fared relatively well. I think it was 5th in the country in terms of keeping people who are eligible in their Medicaid. But to do that, it took 16 touches per person. So they were reaching out at least 16 times in some fashion, whether it's a phone call, a church visit, a community organizer, going to talk to them about their eligibility. That is a Herculean amount of people and effort. And to do that now from year after year is not a terribly sustainable approach. What we're trying to do is we're trying to say, hey, is there any way that the state can link health infrastructure with employment infrastructure, right? Like people pay taxes, who's paying labor taxes. Maybe we can link employment data to health data so that the state can just standardize these eligibility processes so that we don't leave it to folks to fill out paperwork every 6 months. These are the kinds of conversations that we're trying to have to stave off these administrative complexities and the loss of coverage. So I find my optimism from these state level conversations. There are people who are trying to be really creative, people who are trying to create new job programs, work training programs. This is something historically we in America have not been good at, right? We have not been good at understanding what to do when there's a change in industrial classifications, right? We have lost so many jobs to automation, so many factory jobs. We are still reeling from those employment changes. Now, over the course of the next year, we're going to have to find a way to get people into these programs, get people to have conversations about what useful job training looks like. And while that's really scary, I think there's also just tremendous creativity there.
So talking about program development, so other than the fact that within our FQHC we have an eligibility department, and then we also have navigators who are out there continuing to tell folks, hey, you need to check your renewals, you need to check this and this and that for your continued Medicaid services. So what we've actually started is a pilot program that we started this month and going to continue till next month, which is a greeter program. We did it at one of our 6 campuses, so we're just doing it at the main campus that kind of has the other types of services, so our lab or our radiology or our x-ray, et cetera. And so we're starting it with the CHWs, and so we've created a list of questions so that the CSRs are not bombarded, because you have patients that are walking in and sometimes we have these lines, and so they're not always there for a medical appointment. They might just be there for a lab draw, or they might just be there for x-rays. And so then the greeter can go up to the patient and say, "Hi, can I help you? Why are you here?" And so if they're just here for x-ray, then they can walk them over and it's a warm handoff to the x-ray department, or warm handoff to lab, or referrals, or wherever it is that they're going. Or it might just be to pick up prescriptions at the pharmacy and nothing else. So kind of getting those minimal types of job skills that somebody can do for hours to kind of go for that entire incentive thing.
Yeah, I'll just add, we're very concerned in Louisiana. 1/3 of our population is on Medicaid. And, I've heard projections as high as 700,000 could lose eligibility. And, as the payer, that affects us as well. And so our navigators are actually all prepared, and we know we will use that division to try to help with all the paperwork. I have some serious concerns about whether the state will even be able to process it. We're not all that advanced in some ways. I don't know if Keith is in here, but he knows. And and so I am very concerned at what happens. It's a huge number of individuals that could, lose their benefits, and we've got to do something about it.
Definitely. We will take some questions from the audience, but while people are thinking of their questions, I just want to put in a plug for the NCCRT resource on rural health. So it is a guide that is called The Guide to Increasing Colorectal Cancer Screening in Rural Communities, a practical guide, and that was out just in the past year. So anybody that's interested in rural health should look at that guide. Let's take our first question here.
Thank you all for speaking to this topic. And Nate Merriman, Intermountain Health, and then full disclosure, I grew up in healthcare and medicine in North Carolina at UNC Chapel Hill, and my first rotation as a third-year med student was in rural primary care. So I share that background just because I realize not every GI physician, at least at Intermountain, shares my same passion for rural medicine. I really appreciate the comments about broadband. There are so many assumptions I think we make about how patients can just use their phone, and well, that's not true if they can't use their phone to get in touch with us. And so what we did was we had learned from the oncology team site to site access at each of the rural primary care sites and integrating specialty care into rural primary care on location. And then so we started that up. I learned from oncology. We just spread it to GI. We're trying to add endocrine, rheumatology, some of the other specialties. And I'm curious if you all have seen that, if that model is potentially scalable, not everywhere necessarily, but broadband is often on location at rural primary care. And just last thing I'll say is reading through every rural primary care note, and they're averaging 15 to 20 problems per patient. And if we can just take off 2 or 3 in GI, I feel like we're helping, and not as much as we could. So trying to also add the CRC screening conversation to every visit with every patient that we have in GI and rural. So any comments?
Yeah, I was going to say I love the idea of figuring out a better way to integrate specialty services into telehealth. And we have not done as much around that in Louisiana. We have the old telehealth system where you went to a certain location. That has not been used or has not been very effective. What we have done in some of the clinics we work with is work on transporting patients into the primary care clinic where they've got a room that they can then help facilitate visits to a specialist. That has been somewhat effective. It's 2 different problems in Louisiana. We have the dense urban center where it's not an issue to necessarily have a provider. It's an issue to get an appointment. And then you have the rural ones where the closest person is 115 miles away. So I think there's still a lot to solve on that.
And I'll just add, I think the VA has done tremendous innovation about telemedicine, and I'm specifically thinking about these hub and spoke models in terms of promoting access specifically as it relates to specialty care. They have, as a federal health system. They have some advantages that make it harder to implement elsewhere. But the point is so well taken, is like whatever you can do to increase points of access.
Stoney.
Sure. Stoney Anderson with the California Colorectal Cancer Coalition. And we're working with our, we call it Medi-Cal, but it's our Medicaid managed healthcare plans. And there's not much information on how health plans can help the clinics increase their screening rates. So I have a series of little questions for you. First, when you're doing, it sounds like direct patient care with navigation and maybe even more than that, how do you make sure that the personal physician gets the information or the clinics get the information, or do you have clinics as a health plan like the Kaiser model where you contract with clinics? The second, how big is your health plan right now? And I would also love to hear more about, because that was one of the problems with adding colorectal cancer screening. They were worried about how people would have a health plan, but they would change clinics. So this registry of people that have been screened would be something, and because that saves them money, that we could sell to the people in California or throughout the country. So that's the series of about 3 questions. Thank you.
No, I'll try to keep them all straight. Well, I'll start with the size. So we're over 150,000. I think we're actually approaching 165,000 right now. So pretty significant within the state of Louisiana. As far as how we do the care, so we're very integrated with our provider network, because a lot of those providers were the ones that founded us. And so we've always taken the approach of minimal to no abrasion with the provider network. And so to that, when our nurse practitioners or our navigators are interacting with what we call the members, we always provide that information to the providers, to the physicians and the nurse practitioners, that are caring for them. And when we encounter something, for example, a positive screen that needs follow-up, we actually pick up the phone and we call the PCP and actually have a discussion with them. That's something that I'm very firm on. It's that person to clinician to clinician conversation that is really critical. Yeah, and I think on the ROI pieces, it's again, you have to kind of think like a payer. Money does matter because you're trying to build your benefits and support your company and everything. But I think one thing I recognized kind of early on is that payers only think 1 year at a time, because everything is budgeted. It's all based on the bid. And it's very frustrating sometimes to get people to break out of that, because what you do today is going to save you tremendous amounts of money in 5 years. And so you've got to get the rest of the C-suite to understand that. I'm very fortunate that my CEO did, and that's why we've been able to do some of what we've done.
All right, Steve.
Thanks so much. The question I have relates to really the scarcity of primary care providers in rural America, and also the stability. And what I mean by that is 2 years ago at this meeting, when we were shining a light on Alaska Natives and indigenous populations and their inequities, I had lunch with some folks who may be aware of something I was completely unaware of, being a New Yorker, living in urban America, and that is that a lot of the primary care doctors and even the specialists on reservations and other rural areas are international medical graduates who come to this country. They train very well, they're really well trained, and then they have a payback for their visa. They have to go to an underserved area for 2 or 3 years to pay back their visa. And I have to say, I was in charge of our GI fellowship training program for 23 years, and I always thought that was a great program, right? We're getting really good, well-trained people, we're putting them in underserved areas, and we're going to save the world. But from the people that are living there, what I learned was that they knew that these doctors were only there for a year or 2, and then they were going to leave. So the community, the local community, didn't feel that they could establish a relationship, a trust, because once they did that, the doctor was gone. And so that gets to the stability of the providers in rural areas. I wonder what your thoughts are about not only the number or the scarcity, but also this program, which is meant to help, and I really wonder how much it's actually helping.
Your point is so well taken. As a descendant of one of those international medical graduates who practiced for the Indian Health Service, my earliest memories of medicine are that, actually. It's not a durable workforce in some ways. I think it speaks to a broader challenge where I think the answer is the same. I hinted a little bit initially about how there's a lot of sort of payment strategies trying to sort of financially sustain rural hospitals. A lot of those payment strategies are also trying to attract workforce. It's very hard to attract workforce to communities where the economic opportunity is limited, where populations were out-migrating. I will say that the out-migration from rural America actually stopped after 2020. Now we're seeing growth in rural communities again. But still, you have a lot of economic challenges in these areas that make it hard to sustain a workforce for a variety of different industries. I think healthcare is no exception there. My soapbox on this is that I think to sustain rural health care, you have to sustain rural communities. Otherwise, you're just paying into a healthcare industry by using like a bucket to empty the ocean. And whatever well-intentioned payment policies or workforce strategies you may deploy, they are limited from reaching their full potential because there's no opportunities for people to stay there. There's no school infrastructure. The local governance needs resources. And so trying to a lot of these are Band-Aids for a really tough wound. And I think part of my optimism about some of these rural health transformation program ideas that are coming out now are that they are interested in combining workforce, economic, and health challenges to sort of give a big push intervention. I mean, we all know about social determinants of health, and yet we all treat them as though if we isolate one in particular, the others will go away. But unfortunately, that is not what theory would predict. That's not what reality shows. And so I'm encouraged by some of these policy efforts that allow for sort of a big push of these different components to try and get at the point that this very intractable problem you're raising.
And if I might add to that question just a little bit. So within Mariposa, within the last year, we've actually started a residency program ourselves to try to really make the area engaging and then retain those providers. Because we have that same issue. We've had providers that come and do their rotations and then they just leave and then they're not there and patients cannot establish that care. So we're phase 1 of 3 with our GME program, hopefully getting those residents to maybe stay in
fantastic.
our area. So
That's great. So great to hear that.
That's great. Let's go to Rich.
Yeah, just to respond to that last point, not what I was going to say, but if you look at what's happening to people entering residencies in primary care, it's not that encouraging. General internal medicine has been on decline for years. Family physicians, U.S. grads are flat. International grads not going up to the extent, and the recent rules are going to make that more difficult. The big growth in primary care has, including in rural, has been in nurse practitioners and physician's assistants. So somebody mentioned earlier today really understanding the workforce and how we support it. Paula, appreciated all the comments, but you've expressed some optimism about some aspects in the Big Beautiful Bill. Hard to say big beautiful. I have trouble with that. I'm sure I'm not alone.
HR 1 is good.
Yeah, there you go. Could you just walk us through that a little bit more? What is actually in the bill? I mean, it felt like more of a, we need more support for the bill, so we're going to throw some rural money, rather than a really thoughtful approach. But you have some optimism about it, and I wonder if you could walk us through it a little bit more.
You're totally calling out my optimism. Rich. You're totally just being like, really, Paula, really? I'm happy to talk about some of the high points that are in HR 1, specifically as they relate to safety net populations, perhaps, just because I'll tell you that the table of contents for HR 1, the section on health is so long that it only rivals that section on taxes. So even though this was meant to be like a budget reconciliation bill, don't get it twisted, it's a health care bill in a lot of ways. In relation to safety net healthcare, there are substantial changes to the Medicaid program. We've talked about work requirements. There's a funky Medicaid financing strategy called provider taxes, which states have relied on to make up the payment difference between the fact that Medicaid as a program reimburses less than commercial payers and Medicare. The reason is that Medicaid is funded in part by states, and states have to maintain a neutral budget. They can't go into debt like the federal government. So that's the root of that reimbursement challenge. States have used this strategy to try and make up for that challenge, and that strategy is like the knees are kicked out from under it a little bit in H.R. 1. There are a lot of aspects of H.R. 1 that also undo parts of the Affordable Care Act. There are subsidies for people to purchase insurance on the marketplace exchanges that are going away. That was in part what a lot of the government shutdown was about. There are limitations on clinical services, access, and insurance for many immigrant populations. There is a big financial hit for Planned Parenthood organizations around the country and in relation to whether they can even access funding from the federal government. The answer is no. So I won't go on because who wants to be that Debbie Downer? But there are a lot of challenges related to Medicaid, related to undoing components of the Affordable Care Act. Where this all shakes out, we'll see. I think there are reasons to be concerned about disenrollment and people being lost on Medicaid rolls. I think what happens then is that uncompensated care goes up, right? That means that more care needs to be provided that is for charity purposes explicitly, or in the name of quote unquote bad debt, right? That's care that healthcare providers provide that they intended to be paid for but don't get paid for. And I think those are sort of some of the challenges that we'll be living in a little bit. How do we deal with this new landscape of uncompensated care? And we'll have to see how states meet this challenge, a lot of which depends on their current administrative capacity. I'm still an optimist, Rich. I agree with your sentiment that the point of the Rural Health Transformation Plan was to aggregate votes from senators who had concerns about rural healthcare facilities and their reliance on the Medicaid program. Fully agree.
Yeah, and just to add, there's $50 billion, and $25 billion gets dispersed to states, and the other $25 billion is competed for through proposals that states provide. So it's a substantial amount of money. Anything else, Brent?
Yeah, I was just going to add that I know when I have this debate with my friends, a lot of people think this only affects people on Medicaid, and that is so false. And, again, from the payer perspective, those UCC rates are going to raise DRG payments at hospitals, and what do you think the payers are going to do to the premiums in order to cover all that money? So, I mean, this really affects everybody in the country, so we need to pay really close attention.
Yeah. Heather, let's get to your question.
Yeah, it's building off of Rich's question and about this rural health transformation grant and the billions of dollars. It does feel like a little bit of smoke and mirrors to cover up what the harms may be from the H.R. 1. I'm wondering if you could speak a little bit to the realistic sustainability of what those funds could potentially do. I feel like once 5 years end, the money's gone, then what happened? If you could speak to that, and then also, in your opinion, do we feel like that money will actually get to the rural folks and the facilities within the rural areas of our states? Thank you.
Thank you. It's not clear sort of what the ultimate financial benefits of the Rural Health Transformation Program will be. What I'll say is that states had to put in proposals for what they would do with this money on November 5th of this year. They had about 8 weeks to put proposals together. I've started to hear some conversations about what people are planning to do with that money. A lot of it is telemedicine. A lot of it is community health worker models. Some of it is pipeline programs to sustain a rural healthcare workforce. What's interesting about the stipulations of this fund are that you can't use it to pay healthcare facilities, actually. And you can't use any of the dollars from it to build anything. Construction is not allowed. And so it's a little hard to address some of the like structural like features. A lot of rural hospitals are old Hill-Burton hospitals from the 1950s where infrastructure would make a massive difference for them. Man, don't you wish we could build? But you can't with these funds. And so there's a lot of interesting allowable and unallowable costs, and we'll have to see a little bit in terms of where it pans out. I'm sorry, your second question. Do you mind just shouting it?
Will the money actually get to?
Oh, great question. Yeah. It doesn't have to, right? So states can propose to use the funding for a variety of different purposes. It does not directly, it can tangentially meet the needs of rural people, but does not explicitly have to do so in all cases. The other thing I'll say is that this program is one of the few pools of money that will be flowing from the federal government back to states. So you can imagine that like everybody wants a piece of it in states, you know, it's like, it's one of the few, for now, perhaps that pipeline might change, but it's one of the few things that they, you know, that will be going into states, not coming out of them. So it's, I'm hearing a lot of conversations about it's gonna serve a lot of different random purposes that, you know, states will need to fill.
I wanted to get to you, Patty, because obviously your clinics operate along the U.S.-Mexico border, and you mentioned earlier that some of your patients go into Mexico for care, even oncology care. Are there things that we should be learning about how healthcare is delivered in other countries that we can apply to the U.S.? And I guess from your experience operating on the U.S.-Mexico border, are there some strategies that are used in Mexico that would be helpful in the U.S.?
I actually don't know. I'm not sure about that in terms of Mexico. All I know is that if a patient cannot travel north for whatever reason, and there is a Border Patrol checkpoint, so if they can't travel north, then they'll travel south to get their care because we don't have oncology services in our area.
Yeah. And do you typically get those records back in your clinic?
If they are our patients and they're working with one of our community health workers, they will. Our community health workers are all trained in the electronic medical records, so they can put that information in the notes section. And then if they have a PCP visit, then they'll read that.
Yeah. How about you, Paula or Brent? Anything that you feel like we should learn from other countries?
Yeah, I think we could learn a whole lot from other countries. I mean, I think in particular, the disequity in our system it's been clear for quite a while, but I think it's becoming even more and more clear. You know, Patty and I were talking earlier. One of my other hats, I run a nonprofit free clinic in New Orleans. And we see 95% Latino patients. And, you know, we're about to experience an onslaught in our city. And so we're trying to kind of figure out how are we going to navigate that, because the care doesn't stop. And I think we've got to start really taking a serious look at you know, who do we want to be, you know, and what type of health care do we want to deliver.
Anything to add? No. Go ahead, Rich.
There are empty microphones. I can't tolerate an empty microphone. A two-parter. Just to keep the depression going, to balance out any optimism. Yes.
Yes.
Would any of you comment on the...
Say something cheery, please.
This is not cheery. On the rapid entry already there of private equity, who specifically looks like they're going after financially distressed institutions, taking the assets out of them. So that's a big lift me up. And my totally unrelated two-parter, we've talked about telehealth. We did not talk at all about, we didn't use the term artificial intelligence, I don't think. I'm scared and excited about AI, and I think it's two-tailed. You could go in either direction. So those are private equity, AI.
And you understand we're all going to listen to country music tonight. This is really dangerous.
Private equity. Over the past few decades, private equity firms have been coming into a variety of different healthcare service markets, inpatient, outpatient, across specialties, optho, cardiology, hospitals, gobbling them up, changing a variety of procedures to turn a profit and then resell, similar to how they approach other markets. Private equity in healthcare, I will tell you that the causal evidence that we have is that it's bad for patient experience, it's bad for mortality for some conditions, especially for nursing homes. There's really powerful evidence that when PE firms go in and gobble up nursing homes, that it has an impressive and sad mortality consequence. There's one place where PE seems to do better for patients, and that is the IVF market, where patients seem to have more satisfaction and have some better outcomes as well. But most of the examples are sort of on the other side. I think one of my favorite and sad papers about PE is that when you look at when PE gobbles up ophthalmology practices, clinicians are less likely to provide retinal detachment surgeries, which is to prevent blindness. And the reason is because it takes time. It's like a time-consuming procedure. And so those are the margins on which they're trying to cut. That one particularly hurts my heart. I wish I had a better thing to say about PE. Sorry, guys. But I do think that it is prompting interesting regulatory conversations, right? Like, people are talking about, when do we allow PE to enter into a transaction? What can the Trade Commission do to sort of provide more oversight of these transactions when they happen? If they're going in the wrong direction, can we rein them back? Like, it's at least starting these conversations about what does an appropriate regulatory environment mean, so that, business can do business but not hurt patients at the same time. AI, right? I don't know if any optimism about AI. Mine is mostly just terror.
We need to a little. Actually, I will tell you where we are already using AI in a couple of scenarios. I'll tell you on the healthcare delivery side, where it has been extremely useful is we use eClinicalWorks, and if you've ever used eClinical, it's all about the jelly beans, which is these little messages you get, and sometimes the providers will have thousands of jelly beans, and we use AI to actually triage them. And it has been really kind of transformative, because there were so many things that if you started at the top and made your way down, you didn't get to the one that was really important. And so I think that is one way that I think AI will help. I think in ambient listening, it can be really fantastic. The providers that I employ anyway that use ambient listening have less burnout. They're more likely to stay, yeah. And the one thing I always remind them, though, is you have to proofread your note, because it will pick up some wild things and put them in there. So that's the only struggle. But I think it is going to be good as long as you don't use it to replace common sense.
And I'll just say my general concern, my deep dark concern about AI is that it will distract us from the fundamental drivers of health that we know are hard to fix, right? Like, you can't AI your way out of joblessness, or we're trying. You can't AI your way out of low social capital, some of these durable infrastructure features, but it's a pretty distraction to pay attention to.
I think it's being used a lot for improving imaging as well, which I think has tremendous potential. And I didn't know that this panel was going to be about uncovering Paula's deep and dark concerns. So I want to try to end on something that's maybe like a visualization. So for, many of you think about rural health all the time, and Paula, thank you for kind of creating this idea of how we potentially need more smaller brick and mortar locations or neighborhoods, so we can deliver neighborhood-based care, right? So what is the image that you guys have for the perfect system that obviously doesn't exist, but this money that's being offered? Like, if you were the one that got to dictate how this money could be used in your state, what would be the things that you would invest in, or what's that vision that you have that could really make a difference in people's lives?
Mobile health units in communities, neighborhoods, where people cannot access the health centers themselves. So I have a visualization of an actual unit that will drive around to different communities on different days, and they're going to offer vaccinations and checks, and the same thing with a dental mobile unit, and have that same type of thing. So bringing the services to the people where the people or when the people can't come to the clinic.
Wonderful, wonderful. Brent, how about you?
Not a brick and mortar, but I think the work we've done with our clinically integrated network could be expanded greatly, because the majority of our providers that are in it are rural, and we are able to provide them support through the clinically integrated network that they would never be able to afford on their own. So things like community health workers, social workers, RNs, all of that to help them support their practices and not get burned out from what they're trying to do.
Paula, I know it's dangerous, but Paula, Paula, try to be positive.
No. I find myself thinking a lot about local governance these days when I'm thinking about rural health. And the picture I have in my mind, amorphous at best, but is sort of a reconceptualization of what an anchor institution is for a given community. It doesn't have to be the hospital. It can be a church. It can be a factory. It can be a plant. Whatever is binding that community together and starting with that anchor institution, and then figuring out how to connect that institution to building school infrastructure, building social services, then building healthcare, because unless you have something that sort of is anchoring people to places beyond just, the place, I think it's just hard to build without that. So that's an amorphous thought, but a concept I find myself coming back to.
What about, and what just popped in my head, are school-based health centers? Yeah,
Yes.
that serve not just the students, but the entire family, right?
Exactly. And healthcare is such a dominant industry in the United States. I don't make friends by making this point, but you wonder if maybe there's opportunities to pay attention to the sectors that matter to people more, instead of saying healthcare can save everything for you. I wish it could. I wish it could. I wish I could fix everything when someone is in the hospital with me. But the reality is they live in the world. And so you wonder if maybe there's a better starting point.
I learned so much from all of you. This was such a great panel. Thank you so much. So join me in thanking our panelists.